So these are all drugs affecting blood pressure. Um, so we're going to first be going over the antihypertensive agents. So the first drugs that we're going to be going over are drugs affecting the renin, angiotensin, aldosterone system. There's two hypertensive drugs that are associated with this system. But first, like before getting into the drugs, we're just going to try to understand the system first and why it plays a role in blood pressure. So the RAS system is a hormone system that regulates blood pressure and water fluid balance. The second mechanism by which drugs act to lower blood pressure is to suppress the activity of angiotensin 2 in the RAS, which we'll cover. Angiotensin 2 causes potent vasoconstriction and the release of aldosterone, which increases the retention of sodium and water. So whenever you have a retention of sodium and water, that increases your blood pressure. And whenever you have vasoconstriction going on, that also increases your blood pressure. Because what we want with patients who are hypertensive, we want vasodilation to occur. So by blocking angiotensin 2, vasoconstriction and aldosterone release are likewise limited, and volume expansion decreases. So this will reduce your SVR, which is your systemic vascular resistance, which basically is like another word for that constriction going on, and also will reduce the cardiac output. And then both of those things lowering will lower the blood pressure. So these are the steps of the system. So step 1 is the release of renin, and then step 2 is the conversion of angiotensin to angiotensin 1. Step 3 is the formation of angiotensin 2 by the enzyme angiotensin converting enzyme, which we're going to be covering ACE inhibitors. So by blocking this from occurring, we're thus like not letting any vasoconstriction or retention of sodium and water happening. But then step 4 would be the adrenal cortex gland will be triggered by angiotensin 2 to release aldosterone. So aldosterone will cause the kidneys to keep sodium and water and excrete potassium. So step 5, the pituitary gland, which is in the brain, will be triggered by angiotensin 2 to release antidiuretic hormone, causing kidneys to keep water. So this is just a little key whenever like a patient's like retaining water or anything, blood pressure goes up. So with high blood pressure, we want to block this system. Okay. Does that make sense, this system? Because it's basically just a system that causes vasoconstriction. Does this make sense?
Yeah.
Okay. So
Yes,
now we're actually, all right, good. So we're just gonna get into the drugs now. So I'm trying to make it sound as simple as possible. So this drug is the angiotensin converting enzyme inhibitors. So with this drug, we want to block the ACE inhibitors. So we're blocking step 3 from occurring. And then if we're blocking step 3, this won't happen, and then we won't retain all that sodium and water, which will, cause an increase in blood pressure. So these drugs end in pril, so they're pretty easy to remember because they have a common suffix. And then it's like a memory trick. I got the trick from Level Up RN. That her videos are really helpful too. So I used to watch those a lot, especially for Dr. Balkan's classes. So the memory trick is playing cards. When you get an ace, you get a thrill. So ACE inhibitors end in pril. So thrill, ace. So it's a little way of remembering that. So indications, and it's a hypertensive medication, but it can also be used for heart failure, myocardial infarction, which is another word for heart attack, and then diabetic neuropathy. So a little note, so this medication lowers blood pressure only. It's not going to lower heart rate. Because with other medications like beta blockers, they lower blood pressure, but they can also lower heart rate. So whenever you take vital signs before a hypertensive medication, you want to check both. But with this one, you primarily just want to check that blood pressure and make sure it's not too low before giving this. So that's sort of the key with all hypertensive medications. You never want to give someone a hypertensive medication if they're blood pressure is too low. Even if they're scheduled to take it, you don't want to give it. So mechanism of action, like we said, so blocks conversion of angiotensin 1 to angiotensin 2. So we are blocking step 3 from occurring, which will then, block these step 4 and step 5 won't happen. So, the blood pressure won't increase then. And again, this is a normal system that happens within our body. All right. So we're just trying to block it to lower the blood pressure. So contraindications is pregnancy. So I know Dr. Balkin sometimes likes to ask questions with medications that, you can have during pregnancy, and then other medications where you can't have during pregnancy. So this one is a no-go for patients who are pregnant, okay? So these are some of the side effects. So a way to remember it is ACE, the acronym. So angioedema, cough, elevated potassium, hypertension, and dizziness. So if you remember when we said over here, normally within this system, you will keep sodium in water and excrete potassium. So since we're blocking the system, we're going to excrete sodium in water, and, and potassium will stay there. So you want to monitor potassium. Because potassium can actually be really harmful on the heart if it's too high and there's too much potassium in your body. Another side effect would be hypertension and dizziness. Honestly, these are probably the easiest symptoms to remember, hypertension and dizziness, especially with hypertensive medications, because if you lower the blood pressure too much, that patient can now become hypotensive. And if a patient becomes hypotensive, they're at risk for orthostatic hypertension, so risk of falling, dizziness, things like that. And it does have a black box warning for fetal toxicity. So that's why we say we don't want pregnant women taking this medication. So a bit of the nursing care, you want to monitor blood pressure and potassium levels. You want to monitor the blood pressure before and after, because you want to make sure the blood pressure is not too low before giving it. And then after, you want to make sure that doesn't get too low now that you have given it. And you're also checking potassium levels because, like we said, there is a side effect of elevated potassium. So about that. So you also, like I said, you want to pay attention to the steps of the system. If we stop this system, we are now keeping potassium. Keeping too much potassium is dangerous to the heart and can even be life-threatening. So you might have heard some of your professors say, never push potassium in an IV. Same thing with this. You never want to have too much potassium in the body because it's very detrimental to the heart. And then patient teaching. You always need to remember this for hypertensive medications when you give a hypertensive med, to teach the patient to change positions slowly. So remember, if you lower blood pressure too much, they're at risk for orthostatic hypertension and dizziness. So a little note, you want to only hold if the blood pressure is low. You can administer it if heart rate's low because it's not going to have a big effect on heart rate, but primarily we're just getting this for blood pressure, okay? So that's a little bit about this one. So with this one, we're dealing with blocking step 3 from occurring. Now we're going to go into angiotensin 2 receptor blockers, which are our ARBs. This medication ends in sartan, so it's pretty easy to remember because you have a suffix. This medication, again, is for hypertension, but can also be for diabetic neuropathy. I would say you don't have to remember the other indications, honestly, because we're primarily in this chapter, we're dealing with hypertensive. So the indication, hypertension. Same thing with this one. It's going to lower blood pressure only, not heart rate. So mechanism of action, it's going to block the action of angiotensin 2, resulting in vasodilation. So the action of which is step 4. Okay. Again, the contraindications: pregnancy, side effects, hypotension, cough, fatigue, GI upset, and elevated potassium. So these ones are pretty similar. It's just which step in the system. It's mainly the mechanism of action is the main difference with these. Black box warning, again, fetal toxicity, and then you want to monitor blood pressure and potassium. And then you want to change position slowly, and then only hold if blood pressure is low. You can administer if the heart rate is low. Okay. Do you guys have any questions on anything dealing with this system? Okay. So next are calcium channel blockers. So when we're dealing with calcium, if we don't block calcium, calcium can cause hypertension. So with this drug, we are blocking calcium. So the drugs are verapamil, nifedipine, diltiazem. So there's not a common suffix with these, but there's a little trick on how to remember it. So calcium channel blockers are very nice drugs. So verapamil, nifedipine, diltiazem. So VND. So indications hypertension, which is the one we're primarily talking about here. Also can be treated for angina, arrhythmias, preterm labor, which I don't worry about that at all. Nifedipine will come up in your OB course, but for right now, don't worry about that. Mainly, we're just talking about the indication of hypertension. Mechanism of action is going to block calcium channels in the heart and blood vessels, leading to vasodilation, which decreases heart rate and blood pressure. So it's going to calm the heart. This medication lowers heart rate and blood pressure, not like the others, which it's only blood pressure. But so before you're going to give this medication, you want to take the patient's pulse, but also want to take their blood pressure and make sure that it's not too low. Some side effects is peripheral edema, the fluid within the peripheral, so the hands and the feet, as well as hypertension. Um, so hypertension and bradycardia are probably easy to remember with this one, just because if you're lower, because like we said, it lowers heart rate and blood pressure, right? So if we're lowering those too much, then you can end up with hypertension and bradycardia. Another side effect would be constipation and headache, but headache is actually not a side effect. It's actually normal if someone complains about that. So nursing care is that you're going to want to monitor blood pressure and heart rate, and then you're going to hold per provider order parameters. So, you're the nurse, so you're always going to be with the patient, right? You're always going to be giving the medications. So before you give this medication, you want to take the blood pressure and the heart rate. So if you took it and the blood pressure, systolic blood pressure, so that top number is less than 90 and that heart rate is less than 60, you're not going to want to give this medication. You're going to want to contact the doctor and say it's not within the parameters. And then hopefully the doctor says, okay, hold the medication for right now. Because you need that doctor to tell you that you can hold that medication. So then you can hold it if that's lower than that. And then a little bit of patient teaching, you do not want to consume grapefruit juice. A lot of medications, you don't want to consume grapefruit juice. And then another patient teaching, change position slowly. So that goes for all these medications. Anything that lowers the blood pressure, we always tell the patients to change their position slowly. All right, any questions on this one? Okay. Now we're going to go into vasodilators. So the first one is nitroprusside. So, vasodilators, it has it in the word, right? So it's going to dilate those arteries so that they're not too constricted. So by doing that, now we're lowering their blood pressure. So indications for nitroprusside would be you want to decrease the blood pressure through potent vasodilation, which means that it's like going to vasodilate a lot and into where it could possibly be dangerous. So we really do want to monitor those patients. So this medication lowers that blood pressure really fast. So especially in an emergency when you really want to lower the blood pressure, this may be the medication a doctor would want to use. So a key to remember, nitroprusside might press you into, sorry, it was ground when your blood pressure rapidly decreases. So this medication is different from the others because this one's rapidly going to decrease your blood pressure. Side effects, dizziness, right? Dizziness is always an easy one to remember with this one, especially since it's a hypertensive medication. Another side effect would be GI upset. It does have a black box warning for hypotension. So, and it could be severe hypotension because it's doing it really rapidly. Another black box warning for cyanide toxicity, and then nursing care. So say you're lowering that blood pressure way too well. So for severe hypotension, you want to elevate the patient's legs, decrease the dose and increase fluids per order. So, elevating the legs puts more fluid, right? Decreasing the dose and then increase fluids per order. So when we increase fluids ever, that increases blood pressure. Okay, next medication is nitroglycerin, which is also a vasodilator. We talked about nitroglycerin when we went over med-surg, the angina chapters. So this one's probably a bit familiar to you. So indications is angina, which we know is chest pain. So mechanism of action, it vasodilates, it decreases preload and myocardial oxygen demands. Side effects, orthostatic hypotension, headache, reflex tachycardia, interactions, erectile dysfunction medications such as sildenafil, and then patient teaching you probably remember. So sublingual, you want to it's placing it under the tongue, right? So you want to store this medication in a cool, dark place. You can take up to 3 tablets. So you want to place the first one under the tongue, wait 5 minutes. If no relief, you're going to call 911. Take second, wait 5 minutes. If no relief, take third. And then you can only take up to 3. So you probably remember that from med-surg. And then this medication, you can also give it transdermally. And as the nurse, you want to wear gloves, or if the patient's doing it, they need to wear gloves too. Remove the prior dose that's on the skin, rotate sites, and place on hairless sites. So you probably remember nitroglycerin a bit. Any questions on the vasodilators? Okay. Okay, so now we're going to go over diuretic agents. These medications are really important. You're probably going to be tested on this medication. So these are all really important medications. So a diuretic medication is a medication that makes a patient urinate a lot. And by urinating a lot, you're lowering blood pressure because you're getting rid of all that fluid within the body. And whenever we get rid of a lot of fluid in the body, we lower the blood pressure. So the main difference with all these medications is that they just have a different mechanism of action. Okay, so thiazide and thiazide-like diuretics, the drug is hydrochlorothiazide. So as you can see here, it actually ends in thiazide. So that's easy to remember, right? You're getting rid of it. You're getting rid of hydro, and then the chlorine in the body. So hydrochlorothiazide, you're getting rid of that. So, chloride. Indications for this medication is hypertension and edema. So this diuretic agents are used for high blood pressure, but they're also used for edema. All diuretic medications are mainly used for hypertension and edema. So, edema, which means fluid in the lungs, or maybe there's too much fluid within the feet. So those are the 2 indications for diuretics. So mechanism of action is blocking the reabsorption of sodium, chloride, and water at the distal convoluted tubule. This medication is actually potassium wasting. So that's a key with remembering, okay? These are potassium wasting. Side effects, dehydration, hypokalemia. I don't know if you guys covered electrolyte imbalances yet, but hypokalemia just means low potassium. So that can happen, which makes sense, right? Because we just said that it's potassium wasting. And then you're also at risk for hyponatremia, which means low sodium, which makes sense, right? Because we said that we're blocking the reabsorption of sodium, all right? So nursing care, you want to administer several hours before bed because you don't want the patient urinating so much right before bed. That's going to keep them up at night. So usually we like to give a diuretic, morning or afternoon, but never night because you don't want that patient up all night, urinating so much, just keeping them up. Anytime you give a diuretic, you also want to weigh the patients because this is also given for edema. So if these patients have heart failure, like covered in med-surg, these patients may weigh a lot. With that heart failure, with all that edema within their body. So after they give them this medication, you want to see how much, fluid they lost or how much fluid they're possibly gaining. So you always, with this medication, you want to weigh your patients daily in regards to edema, and heart failure. You also want to monitor your intake and output, which is always important because, they're urinating a lot. We want to know how much they're taking in and how much they're putting out. Also want to monitor those electrolytes because we always want to make sure they're not putting out too much where they're losing too much sodium or they're losing too much potassium, right? And then patient teaching, you want to consume foods high in potassium because there's that risk of hypokalemia. So some foods high in potassium are bananas, dark leafy greens, potatoes, cantaloupe, tomatoes, some of those. All right, any questions on thiazide diuretics? Okay. Next are potassium-sparing diuretics. This medication differs from this one because this one's actually going to spare potassium, which means we're not going to have that risk of hypokalemia here because we're actually preserving that potassium, that retention of potassium. So the drug is spironolactone. So you can sort of try to remember it by saying spironolactone spares potassium. So a little key of remembering that one. Indications include heart failure and hypertension. So mechanism of action, it blocks aldosterone, promoting excretion of sodium in water, but retention of potassium. So if you think back to that raw system, if we block aldosterone, now we are promoting excretion of sodium in water, but we're keeping potassium. So think back to that system. Contraindications would be severe kidney failure. Some side effects include hyperkalemia, because think we are sparing potassium. Now we can have too much potassium in the body, right? So that's a side effect with this one. Amenorrhea, which means lack of menstruation. Gynecomastia, which means enlargement of breast in men, and then impotence, so that means erectile dysfunction. Nursing care, you want to monitor potassium levels as well as an EKG. So you want to think of it like potassium levels affect the heart. So we're going to check that EKG as well if we get some signs and symptoms, all right? That including about the heart. Some patient teaching, avoid salt substitutes containing potassium because because we're already sparing potassium in the body for, increasing our intake of potassium. That's really dangerous for the patients. Okay, any questions on the potassium? Okay. Next are loop diuretics. So our loop diuretic is furosemide. Indications would be pulmonary edema, so edema within the lungs, in which we see during heart failure, right? And also regular edema related to heart failure, so both left or right heart failure. And then hypertension as well. So mechanism of action, it blocks reabsorption of sodium, chloride, and water in the ascending loop of Henle, causing rapid diuresis. So this one causes rapid diuresis, which means rapid urination. So a key to remember is furosemide furiously gets rid of excess sodium and water. Here are some side effects. So dehydration, electrolyte imbalances, so hypokalemia and hyponatremia. All right, so we're getting rid of potassium and sodium. Okay, so we want to pay attention to electrolytes here. There's also a risk of hypotension because we're getting rid of so much fluid, right? And this is also a hypertensive medication. So with any hypertensive medication, there's a risk for hypotension. Ototoxicity, so we're dealing with ears here, hyperglycemia, and rash. So nursing care is the same as the other ones, right? So you want to administer several hours before bed if possible to prevent disruption of sleep because, again, we don't want that patient rapidly urinating all night because that's going to be keeping them up. You want to infuse at 20 milligrams per minute. Might not be tested on that though. Weigh patients daily. Again, it's a diuretic. We always want to weigh those patients, especially if they're heart failure patients. We always want to weigh them and see if they're gaining a lot of weight. Are they having too much fluid within the body? That's things we want to monitor, especially with diuretics as well. And monitor intake and output always with these, and always monitor your electrolytes because there's always a risk of something happening here. So just a little recap of the three of these. So this one, you have hypokalemia, and hyponatremia. All right, so there's a risk for low potassium, low sodium. Same with this one, low potassium, low sodium. All right, you want to think of those steps of that RAS system. All right, um, and then here, this one is pretty easy to remember just because it's sparing potassium. So if you're sparing potassium, risk of hyperkalemia, lots of potassium in the body. All right. Next is an osmotic diuretic. Um, this one might come up. This one differs from the other ones because this medication is mannitol, and this medication is used for increased intracranial pressure. So you're going to learn about this. This medication came up a lot in OB, so for me last semester. So with this medication, you can deal with children who have increasing intracranial pressure due to a lot of different reasons. Maybe they have hydrocephalus, which is too much fluid in the brain. This is why you would want to give this medication because you want to get rid of that too much fluid in the brain. Right, so increasing cranial pressure or increased intraocular pressure, so within the eyes, is also given for edema as well. But we mainly use this medication when a patient has too much intracranial pressure. Mechanism of action is going to decrease the increase in intracranial pressure and increase ocular pressure by increasing the serum osmolality. So side effects would be heart failure, pulmonary edema, renal failure, dehydration, electrolyte imbalances, and phlebitis. Nursing care, you want to monitor your weight, eyes, nose, and electrolytes. So as you can see with all of these, they have the same nursing care, right? You always want to monitor weight, eyes, nose, and electrolytes. Anything in which we're getting rid of too much of fluids within the body, you're going to want to monitor that. All of these things, the key three things. And this is the expected range for increasing cranial pressure. I don't remember this coming up for my pharm test, but it did come up in a pediatric test for me last semester. So ICP 5 to 15, IOP 10 to 21. So that's a little bit about these. Do you have any questions on diuretics? Okay. All right. So I think we have a couple more pages. So these are the sympathetic nervous system drugs. So we covered beta blockers before. So just a little review on them. We have non-selective beta blockers, and when we deal with non-selective beta blockers, they block both beta 1 and beta 2 receptors, which can affect the heart and lungs, right? So that can be dangerous for patients who have asthma or COPD, because now we're affecting beta 2, which deals with the lungs. Beta blockers always end in LOL, so they're pretty easy to remember. Indications, hypertension, angina, arrhythmias, MI. Mechanism of action, it blocks beta 1 in the heart and beta 2 lung receptors. So it decreases blood pressure and heart rate. So pay attention, it does decrease blood pressure and heart rate. Not like like the first two ones that we discussed, it only decreased the blood pressure. But with this one, we're decreasing the blood pressure and heart rate. So we have to pay attention to both those things. Before giving this medication. Contraindications, asthma, and COPD. There are side effects of bronchospasm, hypotension, bradycardia, erectile dysfunction, and fatigue. So, with this one, since it is non-selective, there are those possible lung complications. Nursing care, you want to monitor your blood pressure and heart rate and hold per provider's order parameters. So you want to hold if the heart rate is 60 or less, or that systolic blood pressure is less than 90. So again, you're going to contact that doctor and you're going to tell them that it's not going along with the parameters, and then the doctor will say, okay, you can hold the medication for now. Okay. And then we get into the selective beta-androgenic blocking agents. So these are selective. So they primarily block beta 1 receptors, which are mainly located in the heart, resulting in fewer respiratory side effects. Remember, beta blockers do end in LOL. So some indications: hypertension, angina, heart failure, arrhythmias, and myocardial infarction. Mechanism of action: decreases blood pressure and heart rate by blocking beta 1 heart receptors. Here are some side effects. So you have bradycardia, hypotension, erectile dysfunction, and fatigue. It does have a warning for ischemic heart disease if you stop it abruptly. So you don't want to stop the selective ones abruptly. You're going to have to taper it slowly. Nursing care is the same, so you want to monitor the blood pressure and heart rate, hold per provider's order parameters. So if the systolic blood pressure is less than 90 or the heart rate is less than 60. And then the patient teaching, again, with all hypertensive medications, we want to tell patients to change positions slowly and to not stop that medication suddenly. So taper that medication. And then this medication can also mask signs of hypoglycemia, which means low blood sugar. Any questions on beta blockers? Okay. Next are our non-selective alpha-adrenergic blocking agents. So this is phentolamine. So it's non-selective, so it can affect alpha-1 and alpha-2. So indications is for hypertension. So mechanism of action is going to block alpha-1 receptors, leading to vasodilation and decreased blood pressure. Also is going to block alpha-2 receptors, which can increase norepinephrine release and potentially lead to tachycardia. Contraindications, coronary artery disease. Side effects, hypotension, tachycardia, dizziness, nasal congestion, gastrointestinal upset. Nursing considerations, monitor blood pressure and heart rate closely, especially during initiation of therapy, and then you're going to assess for signs of orthostatic hypotension. So all the nursing considerations are pretty similar for all these hypertensive medications. And then you want educate the patients about the potential side effects and advise them to rise slowly from sitting or lying positions. All right, here are these alpha-1 blockers. So some of these are repeating themselves from the autonomic nervous system. So some of these drugs are just repeating themselves. They are in this chapter as well. So alpha-1 blockers. So remember what alpha-1 does. That one is responsible for constricting the artery, so vasoconstriction of the artery. So if we're blocking that from happening, right? So this one is easy to remember because you do have a suffix of osin, okay? So they block the constriction of the arterioles and veins. So now we can use this for hypertension, right? So hypertension is when you have too much vasoconstriction going on. All right, so we can use this medication for hypertension, but this medication is also really common in the hospital setting with older men who have benign prostatic hypertrophy and urinary retention. So it's when their prostate wraps around their urethra and it's causing them to retain too much urine. And whenever you retain too much urine in your bladder and that urine is just sitting there for long periods of time, these patients are at risk for UTIs. So you're going to see this if you do an externship in the summer, you might see this medication a lot on the computers because a lot of older men are on this medication because it's really common to have BPH and urinary retention as an older adult. So yeah, it's used for hypertension, but it's also used for these two things as well. Complications is orthostatic hypotension. So it is used for hypertension. So if you lower too much, you can end up with the dizziness, right? Nursing actions given at night. So it minimizes the risk of orthostatic hypotension. Also, you want to monitor the blood pressure, and then you want to tell those patients to change positions slowly, which is the same for all hypertensive medications. Okay, so you can sort of see like it's a bit repetitive with the nursing care, which makes it a little bit easier to remember with hypertensive medications. Next is clonidine, which is alpha-2 selective. So if you think back to when we went over the autonomic nervous system, alpha-2 was that negative feedback where we don't want to have too much of an effect of something. So now, we're stimulating alpha-2 because it has that negative feedback factor within it. So decreases sympathetic outflow and lowering blood pressure. There's a little key in remembering this. So 3Ds of clonidine, dizziness, which can be pretty easy to remember because, it's a hypertensive med. Drowsiness and dry mouth. And then patient teaching, they can suck on hard candy to help alleviate dry mouth. All right. Any questions on any of these antihypertensive medications? We're going to go into some hypotensive ones. Okay. All right, so antihypotensive medications. So these, we have covered all of these already, so it's just a review. Um, so if you think back to the ANS system and those meds, we have dobutamine, which mainly affects that beta 1 receptor. So this medication is used for cardiogenic shock and heart failure. So mechanism of action is going to stimulate beta 1 receptors and has so mainly it's going to affect beta 1, so it's going to increase cardiac output, and also has minimal alpha 1 activity. So side effects: hypertension, arrhythmias, angina. Because now we're affecting that beta 1 too much. So all these medications are trying to increase hypertension. So if a patient gets too hypotensive, you might want to give them one of these medications. Next is dopamine. So we use this for shock, sepsis, heart failure, renal failure. So this one is going to stimulate alpha 1 and beta 1 receptors. Okay, so whenever we're stimulating a response out of a beta 1, we're going to have some possible heart effects like arrhythmias and angina, right? Next is pseudoephedrine and phenylephrine. So indications would be rhinitis, which is like known as a cold. This mechanism of action, you stimulate alpha 1 receptors causing vasoconstriction of the respiratory mucosa. Pseudoephedrine also stimulates beta receptors, potentially increasing the heart rate. Contraindications: hypertension. You wouldn't want to give this medication to someone who has hypertension because it's gonna, increase that blood pressure even more because we're stimulating, right? So you just want to pay attention to what stimulates, what blocks the receptors, right? So here we're focusing on what's stimulating, so what's increasing that blood pressure. Side effects: nervousness, palpitations, insomnia, rebound congestion, which all makes sense, right? Because we're affecting the heart, that heart's racing, can be known as like nervousness and palpitations of the heart. Interactions: caffeine and stimulants, because if you're having this medication already and it increases your heart rate and things like that, caffeine and stimulants also do that. So it's going to have a really big effect on the heart, which we don't want. So those are interactions and things that you don't want to have with this medication. Nursing care, you're going to want to monitor the heart rate and blood pressure. And then patient teaching, you want to use sparingly due to the risk of rebound congestion. Next is epinephrine. So we covered this one already. This medication is mainly used for anaphylaxis and advanced cardiac life support. So it does stimulate alpha 1. So it does constrict. And then it also stimulates beta 1 receptors, which increase that heart rate. Also beta 2 receptors, right? So beta 2 receptors is really big with epinephrine because it produces bronchodilation, which is really important, especially in an anaphylactic reaction. Side effects: hypertension, arrhythmias, angina, nervousness, tremor, which all those symptoms make sense because hypertension is causing vasoconstriction, right? It's stimulating alpha 1, and then all those heart effects from beta 1 receptors being stimulated. Nursing care, you want to closely monitor your vital signs, EKG, right? Next is midodrine, which is an alpha 1 selective. So you always want to think of these receptors because they play a really big role in these medications as well. So indications: used to treat orthostatic hypotension, a drop in blood pressure upon standing. So you want to give this medication to patients who usually get pretty hypotensive whenever they stand and move. So mechanism of action: primarily stimulates alpha 1 in the peripheral blood vessels, causing vasoconstriction and thereby increasing blood pressure. It can also have some indirect effects on alpha 2 receptors, but mainly here we're dealing with alpha 1, okay? It's alpha 1 selective. Effects: increased blood pressure, particularly in patients with low blood pressure upon standing, helping to prevent dizziness and fainting. Next is norepinephrine, which is a vasoconstrictor. So we use for patients with severe hypotension here. So mechanism of action is going to stimulate alpha 1 sites and also beta 1 receptors. So side effects: hypertension and arrhythmias, which are the main ones. And then nursing care, you want to closely monitor vital signs, EKG, when given for shock. correct hypovolemia before using vasopressors. Okay, so I just wanted to point out that with antihypertensive antihypertensive agents, we are focused on dilating. Focus on dilating those arteries. That's the main thing when we're dealing with antihypertensive agents. That there's too much constriction going on, right? So the blood pressure is increasing, but what we want is vasodilation to be occurring. So that's the main thing with all these medications are doing, right? They're releasing water, they're releasing sodium, causing that vasodilation, and then some of them even target those receptors to dilate. By blocking those receptors, like alpha 1, if you block alpha 1, you're dilating it, right? So that's where those receptors come into play. And then when we deal with antihypotensive agents, so this is when patients have too much dilation, we want those to constrict. So we want vasoconstriction to happen here, right? So you just want to focus on what's going on within antihypertensives and then antihypotensives. So if you focus on that, you should be fine. Okay. Does anyone have any questions?